Well, hello, everybody. Good morning or good afternoon, depending on where you are. I think all of us are close to afternoon by this point, but my name is Garrett Schmidt. I am the managing editor and CEO of bbcexhibithall.com, and I'd like to welcome you all to today's live webinar hosted by ATTAC Consulting, and it is called CMS 2025 Final Rule and Mental Health Parity Rule. Regulatory changes providers and plans need to know. And I know there's been a lot of buzz around this topic, and I'm very excited to hear what our speakers have to say momentarily, as I'm sure a lot of you are as well. We did have to bump up this webinar to accommodate one of the DOL instructional webinars, so apologies for that inconvenience, but glad that those of you who are here are able to make this one. So few items of note before we get started. This is a traditional webinar format, and everyone has joined today in listen-only mode, so you don't need to worry about turning off your camera, your microphone, or anything like that. We can't see you or hear you, but we do want to hear from you. We're going to have a time for some Q&A towards the end of this presentation. So at any time, if you want to ask a question, you have your own attendee control module where you can drop a question in there, and we're going to get to as many of them as we can. We do have a big audience today, and I know there's a lot of questions swirling around this topic. So if we don't get to yours for some reason, don't worry. Someone will reach out and answer your question via email later on. Next, the webinar is being recorded today. So what's going to happen is about, let's say, an hour after we conclude, you'll receive an email, and there'll be a link to the recording itself and also the slides where you can download those, and this way you can share the recording with your colleagues and friends that will rewatch it at your leisure. We hope that you do so. Finally, without further ado, I'd like to introduce our speakers today. With us, we have Ms. Jocelyn Bayliss, and she is the Provider Network Management Division Lead with ATTAC Consulting Group. Then we have Mr. Kevin Malone, and he is a member of the firm Epstein Becker Green. And so they will be our hosts today. But Aaron Green, who's the SVP of Corporate Strategy and Product Development with ATTAC Consulting Group, has a few words that he wanted to say before we begin, and then we'll get right into it. So welcome, guys.
Excellent. Thank you, Garrett. Welcome, everybody. So we have a jam-packed agenda for today. We'll start with the mental health parity rule, and Kevin will cover that from the EBG perspective and give us their opinions and some facts around the new rule that many of you have spent the last couple of weeks digging through. We'll then transition over to Jocelyn to talk about some provider network requirements and some access to care from the CMS 2025 final rule. From a parity perspective, the journey continues. Lots of discussion over the last couple of weeks, additions and subtractions to the requirements, reprieves from things that, were in the draft rule that didn't appear in the final rule that provided some much relieved benefit to many of you. But I think, the bottom line here is we need to keep moving forward on this journey. Not a lot of significant change in the direction that we've all been headed the last couple of years on this. And we keep moving forward. We've had the great opportunity to work with, several people on the call here today, in 20 plus probably plans over the last 2 years. And in each of them in a unique spot and a different spot. Some with blank sheets of paper, some that have been under audit already by the DOL. And sort of regardless of where you are today, now that we've got some finalization to this, I think our best words of advice here are, pick up where you are and let's move this forward to a spot where our beneficiaries can benefit from this. So we'll start today with a polling question, one of several that we'll have today.
All right, and on your screen, you are going to see this polling question. It is, how familiar are you with non-quantitative treatment limits, NQTLs? There's going to be a lot of talk about that today. And that's okay if this is new to you. And this is anonymous. So you can be honest, but we're going to show the results here so you can see where you stack among your colleagues. Um, so I think most of the results have come in. About 65% of you roughly have voted. So I'll give it another 5 long seconds here, and then we will close it down. All right. So I'm going to close it down in 5, 4, 3, 2, and 1. Here we go. Okay. You should see on your screen the results. Kevin, are you able to see
I
this
am,
result?
yeah. And this is great. Thank you very much, Garrett. And this is Kevin Malone, and I'll be taking it over from here to talk through the content quickly on the final rule. I think it's good to see that there's some folks who have some good familiarity, some with some reasonable familiarity, and it's really helpful to know that it's new to folks because it is definitely a word salad of jargon to make it through, and I'll make sure we try to meet everybody where they're at today. So if we can move on to the next slide, that'd be great. So what I'll be talking about today is, the most recent step in a long journey of the implementation of anti-discrimination laws to insurance benefits in the United States with regards to mental health and substance use disorder benefits. So the 2024 final rule that was really just finalized um, a couple weeks ago. Feels like a lifetime for those of us who've been drowning in it, but it is extremely hot off the presses still. Is really the most recent in a long series of efforts by Congress and the federal regulators to address insurance benefits and mental health and substance use disorder discrimination. So as you can see, the parity final rule in 2024 followed the proposed rule in 23, all of which were implementing provisions that were made by Congress in the Consolidated Appropriations Act in 2020. Those were the first substantive amendments to the Mental Health Parity and Addiction Equity Act since its passage in 2008, and really reflected a lot of what had been getting announced by the Departments of Labor and CMS and Treasury, but particularly the Department of Labor about NQTLs and comparative analyses requirements that they'd been issuing in sub-regulatory guidance. For those of you that worked on parity in that time, you're probably familiar with the sort of steady drip of FAQs covering a wide variety of NQTL comparative analysis topics, as well as the self-compliance tool. Those were their primary source of guidance for many years. And the Consolidated Appropriations Act really caught up with a lot of that activity about non-quantitative treatment limits, amended the statute, and now we finally have what I would say is sort of like a reconciliation of the regulatory provisions, the statute, and what had been sub-regulatory guidance. Uh, I will say there is a lot of discussion happening right now among members of industry about whether or not the final rule um, really is defensible and whether there's potential vulnerability for legal challenge under the Administrative Procedures Act, about the contents of the final rule and its fidelity to the underlying statute. But I'm not going to spend a ton of time on that today, but I did just want to signal that the life of the final rule may the experience its own adventure going forward. We can go to the next slide. So for folks that are new to parity, I'll just sort of quickly frame it because it's a really unique regulatory regime in managed care. So at its most basic, it is a consumer protection anti-discrimination law. And it basically has this broad anti-discrimination requirement about the design and delivery of insurance benefits, and requires that insurance benefits can't be designed, structured, delivered in a manner that discriminates against individuals with behavioral health conditions. But and so in that way, because it's a comparative anti-discrimination law, it's very different than what you might experience and what you'll be hearing about later in this webinar today on sort of traditional network adequacy regulations or traditional utilization review regulations, or benefit mandates, prompt payment rules, the sorts of regulations that we generally see of managed care practices. Because parity is a regulation of those practices as well, but is not a substantive minimum requirement. It is a comparative analysis of how medical surgical benefits are designed and delivered versus mental health and substance use disorder. It ends up being a completely different approach to managed care regulation than anything else. And so that's like an important perspective to bring to compliance, to bring to interpreting the regs, and it's kind of behind everything that we're going to be talking about today. So that sort of baseline anti-discrimination requirement is implemented through tests that are different depending on the kind of activity. So cost sharing and quantitative caps on benefits, lifetime and annual dollar limits, things that are of that sort of domain, have kind of their own body of quantitative tests that if you're a health plan, you're maybe familiar with your actuarial and product development teams being responsible for. The most of the subject of today, though, is a different test, the comparability and stringency test, or comparative analysis test that applies to everything else that is the substance of managed care activity, which is referred to as non-quantitative treatment limitations. And a NQTL, as that jargon, as the phrase is described, is anything that a insurance company or a self-funded group health plan and their administrator does that constitutes a limit on the scope or duration of benefits. And the regulators have been very clear that NQTLs cover everything that a managed care company does in implementing and delivering its services. And so in the proposed rule, in response to the proposed rule, a lot of our clients and a lot of members of industry and trade associations, we've been pleading with the departments for years to ask them to enumerate a list of core NQTL types and to define them. Some states have done this by defining things like medical necessity criteria, prior authorization, concurrent review, retrospective review, exclusions, network provider contracting, credentialing. Those are the sorts of things that states that are NQTLs and that have been defined in other jurisdictions. But the Department of Labor and Treasury and the tri-agencies really refuse to do that. So we're in a situation still where what constitutes an NQTL is anything under the sun that a plan does that constitutes a limit on the scope or duration of benefits. And so what the final rules do is change the pre-existing requirements related to the parity test that applies to those non-quantitative treatment limit activities. And if you have been through this process before, even predating the Consolidated Appropriations Act, the regulations required that NQTLs all be defended by a comparative analysis. And the way that I try to explain this to people is that the comparative analysis requirement imposes a presumption of discrimination. And the obligation is you have to prepare a document that tells a story of what the activity is. For example, prior authorization says what the prior authorization practices are at the health plan or the issuer, what benefits it applies to, how it's designed, the reasons it's applied, and the reasons it's not applied to some benefits, the results, meaning the sort of outcome of the application of prior authorization, and a comparison of all of that information between mental health and substance use disorder benefits and medical surgical benefits, and that it's done for each classification of benefits, which means inpatient benefits, outpatient benefits, emergency and prescription drugs, and that has to be done for every NQTL type. So those NQTL analyses, the way I try to explain them to people is they are your rebuttal. They're the story you tell to rebut the presumption that you are discriminating. And the regulations now enshrine what was already in the Consolidated Appropriations Act and self-enforcing since 2021. but requires that you cannot implement any NQTL on mental health or substance use disorder benefits unless you have a comparative analysis that defends that it's not discriminatory. And so that's the framework that we came into the regs with. So we were already, as you know, in an environment with a pretty steep hill to climb. And the regs had initially proposed to include a bunch of new tests that were honestly extremely confounding and didn't necessarily make very much sense. And some of them were replaced or retracted in the final rule. But the final rule does increase the operational requirements about the contents of the comparative analysis. And it still requires us to do everything that I just described. Identify what we're doing, why we're doing it, including the reasoning behind our application of an NQTL and the design of its functions. All of that is still in place. And the most important change really is that they've bolstered what was a previous requirement about the results, the outcomes, to require us to collect and evaluate data metrics on those outcomes in every NQTL type. And that if there are significant differences between mental health and substance use disorder benefit outcomes and medical surgical benefit outcomes, that's a strong indicator of discrimination. So we can go to the next slide and I'll get into a little more detail on some of these changes. So I mentioned from the beginning here that parity is about comparing. It's a comparison between how things are done for mental health benefits and substance use disorder benefits and medical surgical. So before the final rule, under the status quo, issuers and group health plans were allowed to define what mental health and substance use disorder benefits were for the purpose of doing this comparison, as long as it was a reference to a nationally recognized standard or complied with state law. The final rule, and as a practical matter, the way that has played out is that most issuers and group health plans, most TPAs, and many states actually, on the Medicaid side, have specified that intellectual disabilities, developmental disorders, and neurological conditions were medical surgical conditions for the purposes of parity. The final rule reverses that definitively and preempts state laws. So it says, it doesn't matter what a state law says on this subject. Everything that is a mental health condition under the ICD-10 or the current version of DSM are behavioral health conditions. And as this has some pretty significant implications for parity because it limits what had been some discretion about our approach to defining conditions and things that have basically for many years from the beginning of parity been considered medical surgical conditions like intellectual disabilities and particularly the neurological conditions. Those things are now subject to parity and treated as mental health conditions. That's quite significant and is one of the most disruptive immediate requirements that's in effect for January 1st of 2025. And so what we've been working with clients on right now is helping really understand what changes might need to be made on a emergency basis to benefits that have been filed for 2025 and preparing to update our NQTL analyses to reflect this new requirement as to the definition of mental health conditions. Because as going back to the beginning, this test here is about comparing how benefits are designed and delivered for mental health and substance use disorder conditions versus med-surg. And of course, how you bucket things has a big impact on how you perform that comparison. And these new rules change where you're able to draw that line. Next slide. So I've talked a little bit about the NQTL analysis that we now are doing between the mental health and substance use disorder services and the med-surg. And the statute and now the regs themselves require a formalistic 6-step process to be reflected in each of those documents. So I sort of gave it like a pretty quick overview, but the actual steps need to be followed quite strictly, or a NQTL submission that will be made to a regulator or presented to a beneficiary upon request will be found insufficient and therefore presumptively discriminatory if it does not meet these formalistic requirements. And so the first step is, as I said, describing the function. And because the government doesn't define what the NQTLs are, we do have some discretion about how we draw the four walls around a sort of part of our managed care apparatus and define it as an NQTL. And this is often one of the most difficult things for clients to do, is to figure out how they're going to approach the strategy of labeling something as an NQTL. And a classic example is deciding what to do with utilization review determinations for medical necessity for outpatient services when it's a continuing outpatient service that's subject to UM. It's the same exact review that's done for prior authorization, same purpose. You're just authorizing for another set of outpatient services. Is that concurrent review or is that prior authorization? And that question often has significant implications for compliance of the concurrent review NQTL type. And because we have discretion in how we define the NQTL type, thinking through the implications of how we define and label things is really important process in setting up a compliance program. Probably though the most dominant thing that I'll be talking about later, where the definition of the sort of definition of NQTLs becomes most important, is for network provider contracting. So the final rule puts the greatest emphasis across all of its provisions on the management of the provider network. So has been fights for many years but to try to convince the departments that the network is not an NQTL, but that ship has effectively sailed. The departments are very clear that they consider the management of the provider network to be an NQTL for parity purposes, and everything that goes into the composition and the management of the network, including reimbursement rates, are NQTLs, and we have to have tests that prove that those things are performed in a non-discriminatory way. We have to do all 6 of these steps. But because the regulators don't define what those functions are, and in the final rule, you'll see they discuss at length how they acknowledge that there's many, many different functions that are included in the process of developing and administering a network and paying claims. It's up to us to decide how we draw the corners around different functions. And we see a variety of different approaches, and it's something that I think will be of increasing importance now in the implementation of the new final rule, to really carefully consider how you define the NQTL type for network administration as you start the 6-step process. So once you've labeled something, you then are committed to doing this full 6 steps for every classification of benefits where that NQTL is used, and maintaining it over time. And it includes, of course, the definition of the NQTL, describing it, identifying the factors that you rely on in designing it, how they are used and applied. And under the new final rule, there's a new requirement to do that factor analysis for every benefit that's subject to the NQTL. So what that means is, if you say that you apply prior authorization to prescription drugs that are at risk of diversion, you would need to establish in your NQTL analysis for each drug that is subject to prior authorization because it is at risk of diversion, an explanation for why it meets that standard. So as I'm sure those of you who work on prescription drug benefit management, like when we saw that sort of outcome in the final rule, it's fairly breathtaking to consider how much work is going to be involved in updating our NQTLs to do a factor by factor, benefit by benefit analysis in steps 2 and 3. But that is where they adopted it in the final rule. So even though this is the same 6 steps that we may have been living under since, in some cases, before the Consolidated Appropriations Act, the final rule does significantly change the amount of work involved in steps 2 and 3. Step 4 is where you tie it together and you actually do a narrative analysis of all of the facts that you presented in 1, 2, and 3 and explain why we think that it's not discriminatory. That's where you carry the burden of proving that it's not discriminatory and rebutting that presumption. Step 5 is where you pull in the data. And that's where I'll be spending the rest of my time today really talking about the relevant data requirements. And step 5 is where you pull that in. And step 6 is where you do the final conclusion and make the case to the reader that whatever this NQTL type is not discriminatory. So that's the new, it's the new old 6-step analysis that's been in place, as I said, for some time, but the final rule really puts a lot more specificity into each step. So we can go to the next slide and talk about relevant data real quickly. So one of the, if we could go, there we go. Yeah, so as I mentioned, in step 5 of the NQTL analysis, we are required to look at the results, the outcomes of the implementation of the NQTL. If you're familiar with discrimination, anti-discrimination law in the Civil Rights Act, for example, there's often this concept of disparate treatment and disparate impact. So disparate treatment is really, in the parity context, is what's analyzed in steps 2, 3, and 4, the in writing. That's are you doing something discriminatory in the design of this activity? Disparate impact is where you're looking at, is there something, even if there's no proof of discriminatory intent, is there a discriminatory effect? Step 5 is where you have to prove that there is no discriminatory effect of the NQTL type. And this is the place where, historically you've seen stuff about requiring some sort of in-operation data. The self-compliance tool from the tri-agencies always had some really weird stuff at the end about certain measures. The final rule really gives a lot more specificity. And as a part of the proposed rule, they issued something called the technical release, which had a bunch of specific measures about network administration that they were proposing to require. They did not finalize those. They didn't adopt the specific measures in the final rule, but they said they're still considering it and they may in the future. So right now we're in a situation where we can choose the measure still, but they've indicated that there's certain kinds of measures, particularly for network NQTLs, that they're expecting us to have. But where the rubber meets the road is that an NQTL will per se fail if it doesn't have relevant data, unless we can go to the next slide, unless we are able to establish that there's a reasoned justification that no relevant data exists. And they make it quite clear that that's a pretty high burden. So whereas, in the status quo, there's a lot of clients that come in with things like medical necessity criteria or exclusions or things of that nature, where they don't have any outcomes data, but that is no longer really going to fly in the submission of these NQTLs to the tri-agencies. And we have to, they provide some guidance now for the first time about what they're expecting that data to include. It has to have clear technical specifications about the source of that data, like what's the period that the data comes from, the inputs, the basis of making the calculations, and particularly a discussion about material difference, which we can jump to the next slide where I'll talk more about that. All of this data that we are now having to collect for each NQTL type and each classification of benefits is going towards this new standard of material difference. What they're saying in the final rule is that if the data that we're now required to collect on the results of all of these NQTLs, if it shows a material difference between mental health and substance use disorder benefits and medical surgical benefits, that will be considered a strong indicator of discrimination. We have but we can get out of it in our own comparative analysis by doing effectively our own root cause analysis and our own corrective action plan wrapped into the NQTL analysis, and explain that we have taken all of the reasonable actions that we could come up with to try to address the material difference, and that will be satisfactory even if the difference persists. So what they're looking for here, there's a ton of jargon associated with it, but at the end of the day, what they're looking for us to do here is for every NQTL type and every classification to look at the results of it. Denial rates for functions, out-of-network utilization or time and distance compliance or provider to enrollee ratios or things of that nature for network contracting. And we have to report it and maintain it over time. And if there's differences, we have to investigate them and try to do something about it and keep track of how that data and our efforts are playing out. So for things like network contracting, where we have like well-documented shortages of workforce supply for mental health providers, and as we'll be talking about in the next section of the presentation, there's going to be more efforts related to this on the Medicaid side. There's a shortage of behavioral health providers. And if what this is really saying is that in order to stay compliant with parity, we have to be making continuous and ongoing efforts to try to supplement our access for behavioral health providers, or we will be presumptively discriminatory, even if we're not doing anything discriminatory in the design of our network administration on the front end. So it's a big difference. This is the section of the rule that I think is sort of most profound, in that they've taken the focus on from discriminatory design, which is how NQTLs have been implemented basically since NQTL oversight has been implemented effectively since like 2015, 2014, to now where the focus is much more heavily on the outcomes. And it's going to really change the amount of time that we spend thinking about the data decisions and designing your NQTL oversight, and in the sort of staffing of efforts and the budgeting of efforts to try to address material differences when we find them. Next slide. So the natural question on any time you talk about regs is like, well, what happens if we don't comply? What's the sort of enforcement issue here? So the effective dates vary a little bit by provision. So a bunch of stuff, some stuff goes into effect on January 1st, 2025, but other things, including some of the relevant data requirements that I was just talking about, go into effect January 1st of 2026. So we do have a little bit more time to develop those, but as I mentioned, some of the issues related to the definition of a mental health condition actually have some of the most significant operational concerns for benefit design, and those go into effect January 1st. So it's of 2025. So that's already quite significant. As I mentioned, inadequate documentation is definitive noncompliance. And so we historically have always told plans that there's two different ways of violating parity. One is to do something that's affirmatively discriminatory. The other is to fail to have a comparative analysis that effectively rebuts the presumption of discrimination. So even if you don't do anything affirmatively discriminatory, you could still be non-compliant, and the government would sort of hassle you until you got your NQTL analysis back into shape. But in the final rule, they have made it crystal clear that they consider inadequate comparative analyses documents to be discrimination. And if they determine that a NQTL is not compliant, they require you to take remedial action, and they have the authority under the final rule to stipulate specific corrective actions, or to they have the authority to prohibit you from applying the NQTL. So it's kind of unclear what they sort of purport to do here with regards to prohibiting us from doing something like credentialing. But they don't really explore that very much in the final rule, other than sort of inferring that they're not going to like blow up the whole health plan because you don't have a comparative analysis in effect. But they do present that they have the authority under the final rule to prevent you from applying the NQTL at all. There's currently no appeal process, no right for reconsideration. And so the way we've been doing this really since the Consolidated Appropriations Act led to significant increases in DOL auditing is really trying to figure out as quickly as we can how the reviewers are approaching this in each regional office, because it has varied over time. CMS has kind of taken its own approach for marketplace plans and direct enforcement states. And of course, each state is approaching this differently in the fully insured market. I should have mentioned at the outset, and as I segue over to the Medicaid network adequacy conversation, these final rules do not apply to Medicaid. So parity applies to Medicaid through provisions of 42 CFR 438 at the federal level. And these final rules did not change any of those provisions. However, CMS did release with the final rule for comment new templates on parity enforcement that they expect states to start using, um, depending on what kind of comments they receive. So it's quite clear that federal Medicaid is trying to catch back up with the tri-agencies for the commercial market, and many of these requirements we should be expecting that they're coming for Medicaid soon. So with that, I know that was a blast through a whole bunch of parity technicalities, but look forward to answering your questions and turning things over to my colleagues.
All right, looks like we got another polling question here for the audience. I'm going to go ahead and pull this up on the screen. All right. And if you're just joining us late, these are anonymous, but we'll show the results so you can see where you stack among your colleagues. How familiar are you with the tightened network adequacy standards around behavioral health providers? Very reasonably, somewhat, or this is all new to me, and that's okay. We've got a lot of folks here that all this is new for them, so don't feel bad. Okay, it looks like most of the votes have come in here. We'll give it another maybe 5 long seconds. 5, 4, 3, 2, and 1, and then I will go ahead and show the results. Okay, are you guys able to see that?
Yes. That's really interesting. I think there's been so many new rules coming out. It's hard to keep up with sometimes. And Kevin, thank you so much for going over the mental health parity changes and highlighting the different impacts to network. I think that it is going to be interesting. I think over time, working with health plans over the years, we've seen a shift in the focus on behavioral health, whether that shift has naturally occurred through some of the product changes and program changes at the state level, but now even at the federal level where all the different agencies are really focusing in on this. So really interesting. Obviously, I could tell by the results, some of this is new information for some of our audience, but we can go ahead and go into the presentation and I'll go over some of the changes with you all. Great. So just want to make sure that everybody is aware, from a timeline perspective, especially when it comes to Medicare Advantage applications, health plans are building their networks proactively and should be working on building those networks well in advance of the application and network submission timelines, which are in the February timeline for the following year. So for those of you that are going into service area expansions or even new to Medicare, you should be working on your networks now, and you want to make sure that your behavioral health specialties are being covered. I have a feeling, just from what we've seen and what we've heard, that over time, this is going to continue to be a focus area. And one of the challenges as a health plan that we run into is that CMS releases the HSD guidance in mid-October. So team, we are only a couple weeks away from the updated HSD guidance coming out. So keep your eyes peeled for that and make sure you look at the HSD table requirements, looking at the actual behavioral health specialties. Right now, CMS is rolling up these behavioral health specialties into one category for network adequacy. So for a lot of health plans we've been talking to and working with over this past year, they are looking at the specific specialties, but it really is important to make sure you have a plethora. Don't focus on just one or two areas is what I'm saying. Make sure you're looking across the board on these different behavioral health specialties that could roll up and give you credit for adequacy. Next slide, please. Thank you. So these statutory changes were established in the Consolidated Appropriations Act, and it changed these for the Medicare Advantage plans. And these include permitting some of the MFTs and MCHs. So if you're not familiar with our alphabet soup, marriage and family therapists and mental health counselors, they actually are able to enroll and start billing Medicare. So you'll want to check for those, especially as you go through the credentialing processes. And please note that plans are required to independently verify that the behavioral health providers furnish services to at least 20 patients within a 12-month period. There's some reliable sources here. I'm not going to go through each one of them. Just wanted to share those with you as key examples. And outpatient behavioral health facility specialties will receive a 10% credit toward meeting network adequacy time and distance standards. So, it's really important. Look at your behavioral health network, your potential behavioral health providers. We know that there are significant behavioral health provider shortages in certain areas across the United States. And a lot of health plans that we've worked with, we've been helping them get creative on ways to identify additional providers and even atypical providers. As you all know, MA, Medicare Advantage, is one lens, but if you're also participating in a Medicaid program, there's another layer of the state requirements that you need to be considering and really looking at those through multiple lenses to define your strategy. Next slide, please. And then from the exchange perspective, any health plans that operate on the exchange programs, they're also required to meet time and distance standards for provider access, and that's actually going to begin in 2026. They will mirror the requirements for plans operating on the federal exchange, and plans really should be reviewing their networks and begin to prepare to meet these new requirements. As a best practice, it's really important that you're looking at your network adequacy on an ongoing basis. At minimum, I would recommend 90 days. Best practice would actually be every 30 days, if not more frequently, depending on if you have large entities, large companies, provider networks coming into your network that can make a significant impact. Next slide, please. All right, Garrett, we have another polling question.
All right. If you are playing along at home with us, we have another polling question for you. So we're going to pull this one up, keep you guys on your toes here. All right. How familiar are you with CMS and state access to care requirement changes? Very reasonably, somewhat, or again, this is new to me, and that's okay. We got a lot of new folks. We got across the board, actually, in our audience today, which is great. So we can kind of cover the full gamut. And we'll show the results here momentarily. I think most of the votes have come in, so we'll give it another 5 seconds. Close it down and show you the results. 4, 3, 2, and 1. All right. Are you guys able to see that?
Yes. So that's really interesting that a lot of people, it looks like, are not as familiar with this requirement. So we'll make sure we go over that. And there will be additional information that we could provide you as well outside of this presentation if you're interested. We can go ahead and go back to the PowerPoint, please. So when you think of access to care, depending on what perspective you're looking at it from, access to care can mean many things, but ultimately it's about making sure that members are getting the right care at the right time. And the changes that have come down the pike through this beneficiary through state Medicaid agency change, it's all through CMS managed care secret shopper survey requirements, but they put out expectations and specific reporting requirements to ensure timely access to care. And it's requiring that all Medicaid and CHIP health plans develop, conduct, and enforce independent secret shopper surveys to evaluate compliance of appointment wait time standards. You have to have written standards for providers that meet those, as well as making sure you have a statistically valid sample across your primary care, OBGYN, and your behavioral health providers. So behavioral health is important here too, as folks. Contracting with a third-party vendor to administer those surveys, and then the time frame of January 1 through May 31st, those results actually have to be reported by each of these states to CMS by June. So for what we're seeing a lot of the times is that people aren't aware of these changes. We're also talking to some of the state agencies and understanding how they're interpreting this, how they plan to roll this out. And what we're hearing is that several states are still thinking about how to implement these changes. And they believe what we're hearing in the majority right now is that the states will conduct the surveys. However, they're still going to have the health plans be required to complete their own surveys for their specific network and membership. You can go ahead to the next slide, please. And in other cases, we're hearing that in some cases, the states haven't implemented these changes yet. So please understand, these changes are actually effective January 1, 2025, and then they'll be under monitoring in 2028. So I know I've been in the health plan side. When you see the 2028, it's like, oh, okay, we have time on this. We got to focus on everything else that's on fire or right in front of us today. But please be mindful of this. You want to actually start making those modifications as you go into 2025. Make sure you have trends and data and good analytics to support your processes by the time 2028 goes around, and work with your states to understand how they're implementing these changes. I could tell you every state is slightly different from what we're seeing. I think the other item that's interesting is the secret shopper approach. For ATTAC Consulting, when we help our clients with access surveys, we handle plan identified calls. We also offer secret shopper. Plan identified, we seem to get more information of why is there an access barrier. Secret shoppers, you're calling as a member, so you're getting very limited information. But with our processes and our survey design process, we actually are able to get meaningful results in a phased approach. So we do think that this rule will be an impact for sure, but we do think that we can still get the meaningful analytics and results that we've been doing and supporting our clients with. But it's going to be you need to be mindful of these changes and make sure you're implementing them internally. Next slide, please. So there's some challenges to complete these requirements, understanding how each state agency is going to implement those changes, as I mentioned, and then ensuring your provider network is meeting these requirements. So for example, do you know today what percentage of your compliance will states require going forward? Some states, it could be 70% of providers need to be compliant. In other states, it could be 90%. And then I've even seen states where they don't dictate or require a certain percentage, but they hold plans accountable to have a metric and measure against and towards that target. One of the key barriers I find with access to care is the need for education up front. You guys, please don't just put it in your provider manuals and expect the providers to read this. It's all about that front desk office staff who's scheduling those appointments, or that call center, or whoever is handling that for the physicians. They really need to make sure they're aware of these requirements. They are the ones that are going to get these phone calls, and they are the ones the members call. One of the other big challenges I see is data integrity. You really need to make sure that your directories are accurate. We find that on average, about 40% of provider data is invalid or inaccurate when we're doing provider access surveys. So in other words, your members are calling those providers trying to set those appointments, and there's a barrier to care. And then, of course, educating the providers. You want to make sure if they're non-compliant, educate them, help them understand the requirements, and help understand root cause and what you can do to help open access. Next slide, please. I'm not sure. Erin, can we get to the next slide, please?
Should be there.
Okay, connecting with the third party. So survey design process, reporting meaningful and actionable results. One of the key questions is, are you able to identify where access to care challenges are? So a lot of times when I hired survey vendors in the past, they would tell me, oh, you're at this many compliant providers, you're at X percentage, but I couldn't dig into the details. So you really want to be able to dig in and understand, is it a certain geography? Is it a certain specialty? Where are those barriers? And then what can you do about them? And really, again, as I mentioned, ensuring provider directories are accurate and monitoring those access to care results. You guys, it's not just about surveys. It's also about complaints coming into your organization. It's grievances. It's looking at network adequacy. All of those components really feed that overall view and perspective. And I believe we have one more. I think there we go.
Okay. Well, we do have some time for some audience questions. So thank you, Kevin. Thank you, Jocelyn. There's a lot here, obviously, a lot of material that we covered. And don't worry, we're going to be sending you out a recording, a link to the recording and where you can get the slides. But if you have a question, go ahead and drop it in now to your control module. There's a place for questions. We're going to get to as many as we can. If we don't get to yours, though, don't worry. Someone will reach out via email afterwards. In no particular order here, the first question is this. What are states going to be doing to enforce the new federal MHPAEA rules?
Yeah, thanks, Garrett. So the enforcement process for parity. So parity applies to self-funded group health plans that are regulated by the Department of Labor, marketplace products that are regulated by CMS, certain other plans that are regulated by Treasury, but fully insured commercial products, large group, small group, and even individual market in state enforcement states, the state regulator, Department of Insurance, is the primary enforcement authority of federal law. So the states are going to be implementing their parity oversight process according to the new federal regulations starting in January. So the way that plays out is going to vary by state, because parity is what I would refer to as sort of like a soft preemption, meaning that it preempts everything that state laws do that is less protective or less restrictive than the federal regs. So there are states that have certain provisions, like New York, that go beyond and Illinois, that go beyond what federal regs require. Those will still be in effect, still be enforced by the state. So some states require annual reporting and submission of NQTL's benefit designs. Some states do market conduct exams, some states do audits. So all of those things will vary by state and insurance regulator, but they are going to be tasked with implementing the federal regs starting in January. And then Medicaid, as I mentioned, parity applies to Medicaid in a different way, and the Medicaid agencies are the primary implementer of the parity regs for Medicaid MCOs. And CMS, CMS has not revised the regs to mirror the new federal commercial market regulations yet.
Great. Next question here is, I assume that an analysis that was done 2 years ago is no longer valid and a new one would be necessary. How often should an analysis be done?
Yeah, that's a great question, Garrett. So there's, I think that is a safe presumption for two reasons. One is that at minimum, the operations measured data in step 5, that sort of relevant data requirement, that data will be out of date. And so the analysis, we recommend generally that the relevant data section be updated at least every 6 months. And that often is just sort of refreshing tables and then updating the narrative, comparing it. And then if there's a new material difference, doing the sort of remediation investigation that I described. However, the in writing section, we generally recommend that be refreshed every time a significant change is made, or at least once a year. So we have a process where clients do like a full re-review, and that is itself governed by like a parity compliance governance policy that says, as a part of our annual policy refresh, we look at the in writing section, make sure that it actually reflects our use of these activities. The place where things get messed up is they'll include in their NQTL, like they won't keep up with the UM department. The UM department has dropped prior auth and some benefits or added it to others, and that's not reflected in the NQTL. You're definitely your Wile E. Coyote run off the end of the cliff at that point.
Gotcha. All right, next question, moving right along. Do we have to do the same analysis for each benefit for network management?
The same analysis for each benefit for network management. So I think if I understand the question, does the comparative analysis need to be done for each benefit design, even if it's run on the same network? And the answer to that is no. You can do the analysis using aggregate sort of plan or even market level data in certain circumstances. It needs to describe accurately the network that is being used for the benefit in question. So if you have a benefit that has a different network that's run on a different process, you would need a different analysis for it. I hope
And
that
then
answers the question. If it
I think
didn't,
I would just add to that. I think that then they would need to make sure they're looking at the different network management components though for that network, right? So credentialing, yeah, the reimbursement, yeah.
oh yeah, everything. So like all of the NQTLs, the sort of amorphous constellation of NQTLs involved in administering a network, you have to do all of them for the networks that are differently administered.
Right.
I know that that's like a circular answer, but that's welcome to parity.
All right, and then last question, unfortunately, that we have time for, and I know there's a ton of questions, so don't worry. Again, someone will reach out to answer your question. But the last question is Medicare excluded from NQTL?
Yes. Yeah, so parity does not apply to Medicare in any delivery system, Medicare Advantage or original Medicare. So the answer is you just get to deal with Medicare, which is, I think, CMS is enough of an adventure on the Medicare side. There have been proposals on the Hill to apply the NQTL requirements to Medicare Advantage, but those have not been successful so far.
Well, that was a pretty quick answer, so I think we can squeeze one last quick question in here, and that is, will health plans be required to perform and report provider access surveys?
Yes, I believe that they are going to be required to report the access surveys. I think, again, it's going to be state specific. So it's really important that you check in with your state regulators, understand how they're interpreting and implementing these rules, and understanding what your role is and how you need to report that to support the requirement.
Wonderful. Well, that is indeed all the time we have today. I wanted to thank you, Kevin. Thank you, Jocelyn, for a fantastic presentation. Again, there's a lot here. We're going to be sending you a link to the recording and the slides. And thank you, Aaron Eaton. I said Green earlier. Eaton. My apologies, Aaron. Aaron Eaton for our intro. So thank you for that. And as we close out here, wanted to encourage you all to head over to vbcexhibithall.com. Check out the ATTAC Consulting virtual exhibit booth that we have here. There's a lot of really cool resources there, and you can read up on them and what they're doing. And at bbcexhibithall.com too, we have a huge library repository with all kind of different tools and content and articles and white papers for you to do some of your own research. And then finally, if you would like to contact the ATTAC team, feel free to reach out or Kevin. Their information is here on the screen. And thank you all again so much for spending your afternoon with us. We hope that you enjoy the presentation today and will join us on the next one. So have a great rest of your days. Thank you
Thanks,
all.
everybody.
Thanks, everybody.